Hi, this is QD Clinics, and I'm Jack Cush with RheumNow. QD Clinics is brought to you by RheumNow.Live 2023. We'll see you there on March the 18th and 19th in Dallas or virtual online. Sign up now. Our case today is Gottrons papules, but no weakness. A 19-year-old white male, tall young man, looks like he should have been a basketball player, comes in to see me because he's got red rashes over his knuckles and actually over a lot of parts of his body. The rashes are elevated, not painful, not itchy, but they're not only noted over the big knuckles, the MCPs, a few on the PIPs, over the top of his MTPs, over the knees, over his spinous processes, and also over the eyelids. He denies any fever, weight loss, GI symptoms. He denies any weakness. He runs, he works, he has a manual labor job. He has no problems with shortness of breath, no problems with dysphagia. He has no facial rash other than this redness and scaling on his eyelids, and he's not losing any hair. Labs were done prior to my seeing him. His CK was 200. His ANA was negative. His white count and CBC was normal. I did not have any acute phase reactants on this gentleman. When you looked at him, and I've got pictures of him that basically show a truly classic manifestation of Gottrons lesions over the MCPs, where there are scaly, elevated, reddish, purplish, right? And on exam, no swollen joints and no signs of weakness. You know, he has no Gower's sign, meaning he can cross his arms, rise from a seated position without transferring weight or rocking. This is a classic sign of what we would call amyopathic dermatomyositis. Amyopathic dermatomyositis, also called CADM, clinically amyopathic dermatomyositis, CADM, C-A-D-M. The thing about these patients are that they usually have kind of severe disease. A number of them may have progression to actual weakness, but these patients are at higher risk for interstitial lung disease and severe skin disease. In these cases, you should be looking for the MDA5 autoantibody, because that's a marker. It's very common in Southeast Asia, less common in the United States, but we do see a fair number. I've seen a fair number in my career. Been testing for this probably for the last 8 or 10 years maybe. And again, it's estimated that if they have ILD with this CADM, they have a less than 50% survival rate. It's estimated that somewhere around 15 to 20% of them will develop peripheral weakness, motor weakness over time. You have to worry about not just interstitial lung disease, but a risk of neoplasia. And like other patients with myositis, about 50 to 60% are going to be ANA positive. But again, the test you want to look for is the MDA5 and probably doing, other myositis-associated autoantibodies to look at the etiology, including NXP2 and TIF1 gamma, etc. But these are difficult cases to manage. They may be steroid responsive, but often you have to cycle through a lot of different therapies. Many years ago, I used to use hydroxyurea. I've used leflunomide to treat these patients. I have not had much success in managing them with azathioprine and methotrexate. More recently, JAK inhibitors could be invoked if patients truly are refractory. But again, you really have to worry about these people because if they get lung disease, they'll progress rapidly and do poorly. That's clinically amyopathic dermatomyositis, the kind of patient you don't want to see on a regular basis. Take care. Tune in for more QD Clinics.